timestamps here. June June 2nd, she came in for records. November 2nd, she was done. That's 4 months. She actually did not pick up her liners until June 26th. June 26th to November 2nd. Her total chair time was 2 hours. Time with me was 20 minutes. Okay. That is, aside from profit, that is a practice builder. That is someone that you didn't have to explain why they need a refinement. That is not someone that's going to say, oh, I tried Invisalign, it just doesn't work, it didn't work for me. That is someone that has complete confidence in your abilities. That is someone who referred her twin sister with the exact same problem that she had. That was a bonus for me. Okay. So these things are important. To get to the finish line quickly in a GP office is really important because, as we know, in a GP office, we need to turn our chairs. We need to turn those chairs to make a living. And if your chairs are clogged with Invisalign treatments that are not finishing, that keep going into refinements, you're losing a ton of not just money and time, but you're losing goodwill. That's why implementing this in the GP practice, that's what I'm hired most to talk about. That's where most of my training is because we want efficiencies, efficiencies, efficiencies. There are certainly people on this call that can do elastics and buttons with clear aligners that have done a ton more than me that are successful. That's not what I'm going for in my office. And I'm not saying that you are not a success by doing that. You certainly are. But I am here to show you efficiencies and what you can jump in and change on Monday to make your cases finish quicker. Elements of anchorage, there are three of them. Horizontal bevels on premolars, we talked about. Attachments on maxillary anterior teeth, like the lateral incisors. I use optimized lateral retention attachments and a full distal wrap. Okay. This is a case with good anchorage because full distal wrap, two premolar elements, and this is my optimized lateral retention attachment on the lateral incisor. It's one we use the most, almost always on the lateral incisor. Okay. But you have a hug here. So the plastic is hugging the tooth here, providing anchorage. You have trays clicking in here, and you have increased in surface area here on this little lateral incisor where the tray can grab onto and elicit the change that it needs to do. This is good anchorage. If you had poor anchorage, you would have to add a horizontal bevel on the molar. You can ask your software to do it. You can ask your technician to do it. Second topic for this evening or this morning in Detroit. What does IPR mean to you? Well, I guess IPR by definition is a way to make space. Making space in orthodontics looks like this: expansion, extraction, distalization, or IPR. Okay. Right away, we get rid of two of them with clear aligner methodology. We do not want to extract teeth with clear aligners. I've done it. I do a handful of cases a year, and I like doing it, but it's not my it's not my go-to method. And we don't want to distalize in functional orthodontic world. Distalization is a bad word. We don't want to do anything to promote condyles moving backwards. Um, so distalization is not in our vocabulary. At least it's not in my vocabulary. So we're left with expansion and IPR. Okay. But plastic has a limit to expanding teeth. I want to show you this mock-up that I did here. Here's a case that we have zero point 0.5. This is what I call 0.5 wall to wall. I do not go past distal of the canines. Okay. So 0.5 distal canine to distal canine. But I start thinking this arch is constricted. What if we were to move the premolars out? How much of a change can I elicit if I were to move these premolars out? Well, I did this example. I blew out these premolars to like an obnoxious level, which could never happen clinically, but I wanted to show the effect. I moved out these premolars and look at how much my IPR dropped. Now I'm down to 0.2, 0.5, and zero point 0.2. That's a dramatic difference. Okay. Now I reset back to original IPR and I start thinking, I wonder if I can move my molars out. Can I elicit a change if my move? How far can I move my molars to elicit a change? Well, here's what I did. I moved these molars out obnoxiously, something that can never happen clinically. But look at the change I got. Not too much, not too much change at all. Okay. This is probably because from premolar to premolar, it acts more of like a semicircle, and in the molar area, it acts more like a parabola. And those, the interplay between circumference and diameter are different for those two shapes. So we are limited to expansion only of premolars in clear aligners, and we're also limited to having to stay on top of alveolar bone. So that kind of leaves us only with IPR. Okay. IPR, many methods of doing it. And I'm sure if I were to survey the doctors on the call, I would get for sure four, probably eight different methods. Okay. All these are different methods that people come up and tell me. However, the problem with the disc is this: it's not predictable and they say it's dangerous. Okay. Disc can ledge. Okay. Nobody wants to solve this problem. Okay. This is a real grainy picture um, from a trade show that was given to me. This is straight wire, and someone did straight up and down IPR between two central incisors. Okay. That's mismanaged. This This is my former iTero rep. So he worked for Align Technologies, but before Align Technologies, he worked for a company called Dentsply Sirona. Dentsply Sirona has their own clear aligner brand. I forget what it's called. And this young man's treatment plan called for zero point 0.5 IPR right in between the central incisors. Okay. Absolute mismanage of a treatment plan because the same thing could have been accomplished if he were to do zero point 0.2, zero point 0.2, zero point 0.2 safely. Okay. This was done with a disc, and all of a sudden the case fell into my hands in order to fix this. Now, I don't back. I don't know how I was going to fix this. So I decided to squeeze these teeth together just to see if I can get some proper sort of anatomy and morphology of the tooth, but I couldn't. So I ended up spacing them apart again and then just bonding. So once something is done, it's really hard to get undone. And I kind of took the shock value away, but this is my next slide. This is a true slide um, of a split lip from a disc using a disc. Okay. After I see this slide, when I look at this slide, I see so many things that can go wrong that this scares me. Okay. First and foremost, damage to the lower lateral, potential damage to the lip, damage to the teeth on that you're doing the IPR. And the one thing that I notice is, this disc, like dentists be dentists, we will use that disc until it's dead, till it falls apart. This thing has been used before, and it looks like it's like oblong, right? It's not a complete circuit. So once you spin this, if this is a zero point 0.3 disc, you're not going to get zero point 0.3. You may get zero point 0.5, zero point 0.6 in between these teeth because this is not spinning in a concentric circle. Okay. All these things are dangerous points. So here is some disc IPR done. Very, very poor anatomy. I think Dr. Binu was talking about bonding composite to fix these mistakes. This is not my case. I've done this. Okay. I've done this, and it led me searching to a better answer. Okay. These are cases where you can't close the embrasure space because the teeth are touching down below due to insufficient improper IPR technique. Okay. My IPR wish list: eliminate the handpiece, ensure accuracy, make it predictable, make it safe, no ledging, no destroying the embrasure, and keep the tooth contour. I don't want to make toothpicks or fence posts. Okay. Quick strips entered my life, and it has been the saving grace to my orthodontics. Okay. Um, these are called clinic packs. And what we have in the top row is single sided. So, and there's a little card to show you the amount of IPR. The top row is single sided. So it's nice and smooth on one side and sandpaper on the other side. And it goes through all the grits. You have to do it sequentially. You have to do it sequentially. You got to start small, go large. The trick to the system is that it requires a little elbow grease. Okay. Once you work yourself up to the double sided, you know, you've got to lean a little bit distal and you've got to lean a little bit to the mesial. You got to put a little bit of force into it. Okay. Now you don't got to do these big, large hacksaw motions. It's got finger grip, so it's very comfortable. Back and forth, back and forth, back and forth, back and forth. Okay. Um, this is the clinic pack that I use in my office. So the top row is single sided. The bottom row is double sided. Okay. So let's say you needed to go up to a 0.4, you'd go up to a black. You would go single side and then double side up to black. Then you would stop. Okay. Um, I go to I always go larger. I always go to the purple no matter what. Why? Because I like to have a sharp, I like to have a sharp quick strip. I like to have the larger particle size. I feel like I'm just finishing it off good like that. Once you're done your IPR, once you measure, once you're satisfied with how far you go, I go backwards with this bottom row is curved quick strips. Okay. I go backwards from black to yellow or green to yellow, wherever I left off. By going backwards with a smaller grit, you're actually making the pores that you open, you're making the tubules that you open, you're making them smaller. Okay, so you're kind of sealing it up. Um, they make them in zero point 0.6 up to zero point 0.6 and zero point 0.7. Okay, and this is an example of my lower anterior IPR. If I cannot IPR like this, I don't want it. I've done it all the other ways, and no one can get me this with a burr. No one can get me this with a disc. No one can get me this with any hybrid technique unless you finish with a curved quick strip. This is where it's at. This is where you do not destroy the anatomy. Okay. I rarely do past the canine, but when I do, I make it look like this because I have curved quick strips to help me. They are fairly pricey, and I enjoy having a sharp one each time. Okay. But it works for me because in my office, my assistant does this. I finish with the she brings it up to the level. I go and I finish with the curve because I know how much I want it curved. I know how much pressure to put. I know which quick strips to grab to make it curved. So it's kind of like a hybrid technique between my assistant and I. But this is how I need all my IPR to look like. And when I do this in my office, I get my camera and I start taking pictures and I tell the patient, I lecture on this. Yours came out magnificent. I want to take a picture so I'm able to teach about it. And patients love that. And I go into detail about how before we used to compromise the anatomy. We used to make them look like picket fence posts. And that wasn't good. So now I'm thrilled to use this methodology, and I'm happy to share it with you. There is no other way with me. Some people use a real fine burr, then they'll go back with the curved quick strip. And I get it. A hybrid technique is a good technique for speed. But whatever you choose to do, please consider finishing with a curved quick strip, not only for morphology, but in order to go backwards in size in order to seal the tubules. The other thing that I'll mention is you need to go sequential because you don't want to force the strip through the teeth. Forcing it gives you a false sense of IPR. So you really need to put the work into it. And the other thing is the particles are spherical particles. Sometimes there's larger particles, sometimes there's smaller particles. But if you forcefully wedge a strip in between teeth and the space is not there, all of a sudden it's not the particles doing the cutting. What happens is the particles collapse on themselves. And you might get that strip through, but if you don't have that robust thickness of the particles, you are not getting the desired thickness or the desired width of IPR. You follow? So sequential methodology is absolutely critical to your success in IPR because there's so many things going on, not just with tooth morphology, but with spacing that you can get a false sense of security. Okay. Here's some of the bad ones, coupled with the good ones. Here's some of my good ones. I always want it to look like this. Nice gentle rounding, keep tooth contours, and everybody's happy. Okay. The significance of the IPR cannot be understated. Significance of IPR is that IPR is so closely related to refinement rates. And we just talked about being in a GP office. I want to do everything I can to minimize my refinement rate. I want to have a one and done or one refinement and be done. I don't want to redo my IPR. I want to have happy patients that refer their family members. And I need to turn my chairs. I don't want to get bogged down into explaining to people why they need to have a refinement. And I certainly don't want people to question me or doubt me. Okay. This is important because more than half my cases are dependent on IPR. Think about your class twos and class threes. How are you going to manage that overjet if you don't utilize IPR? Okay. And the significance of doing IPR properly. Okay. Any refinement where you have to go back and do IPR again usually means you did it bad the first time. Usually. If you just have to redo the IPR because you didn't do it enough, that's okay. That's fine. Every once in a while that happens. But the problem here, read this carefully. If you don't do proper IPR when you're trying to establish overjet, you're going to end up with an anterior interference. You follow that? If you don't scooch the lower teeth back enough, if you don't scooch the lower teeth back enough, okay? And you remove the aligners and the patient bites down and the incisal edges of the lower incisors are not back far enough, you're going to cause an anterior interference and you're going to get a posterior open bite, okay? That's the importance of IPR. That's why it's so critical to your success. Everyone says, what's the most important part of clear aligners? It's all important and it all interplays together. But IPR, you cannot screw that up, okay? If you get a posterior open bite, anyone that's ever done braces, if you get a posterior open bite, that is significantly harder to solve than just redoing your IPR. It doesn't work that way. Okay. That's why IPR is critical and doing it the right way is critical. My quick strip protocol, stage it. Okay. My max is 0.5 from maxillary distal to distal the canines. Single side, then double side, then step back with your curved ones. Apply fluoride varnish, optional MI paste for 1 to 2 weeks. And from what I hear from Dr. Binu in India, you probably definitely want to do MI paste as mandatory, okay? And reinforce hygiene and fluoride toothpaste and probably 5,000 parts per million above and beyond the MI paste, okay? Here's an example of when you don't do IPR. So there are some dentists out there that just try to minimize the IPR. Well, this in fact is a case. This is a dentist. The dentist is the patient. He did his own treatment plan and he did not include IPR. So we got 4 refinements and nothing changed because he did not want to IPR his upper teeth. Okay. 4 refinements, 10 treatment plans, no IPR. The problem is everyone thinks that they're going to slash and burn the enamel, so that it's irreparable. And that's just not the case. Okay. The real problem is this dentist that didn't want the IPR. This is his brother-in-law. Okay. He's got a brother-in-law and he treated his brother-in-law. Okay. Now let's take a look at these treatment plans here. Treatment plans 1 and 2 include IPR. Look at 0.4 IPR. Okay. Now, the difference between these plans is that he changed out these attachments on the lateral incisors. Okay. Something that we teach in the 4-day course. He changed these to optimize lateral retention attachments. Okay. That's great. He sent it back for modification. Treatment plan number 3, he says, I want to extrude the laterals. I want to close the space. I want to do this, that, the other thing. And I want no IPR. I want no IPR. By definition, a case cannot finish if you don't do what's required of the case. Anything short of that is a compromise. Okay. So treatment plan 4 happens and he does not have any IPR. So there's no appreciable movement. Okay. I enter the game and the case gets transferred to me. This is the first thing I have is IPR. 0.3 wall to wall. How am I going to finish this case? 0.3 wall to wall. It's mandatory. Okay. And we're going to play this through. Lower incisor, scooch, scooch back, drop the top. That's what I call that. Proper overjet, overbite, and the case finishes. This is before and this is after. Okay. Space is closed. That's pretty dramatic for the patient when they don't see those spaces. Patients like that. I urge you to close these anterior spaces whenever you can. People love that. That's a game changer for people. And it's easy to do if you know how to IPR. Okay. Fear IPR no more. You can get quick strips at quickstrips.com. Also at EOC, I think it's EOCA.com or EOCamerica.com. Aesthetic Orthodontic Company of America. They also sell the munchies that we're going to be talking about coming up. Okay. Next up, if there is a case killer, I can tell you that it's crown angulation. And simply stated, crown angulation is if you have to attach a steering wheel to a tooth and you have to drive that tooth into position, that's simply a movement that will not occur predictably because you can't have plastic on the front of a tooth being able to grab it and to turn it. Okay. And there's not enough directed force on long vertical attachments. It's not an optimized attachment. There's not enough force that you can get in order to properly turn that tooth. And it's a root torque movement. So a case killer is crowning, and we're going to see how to manage this and how to find this, okay? First and foremost, you should take a picture and keep this on your cabinet when you're planning your cases. There are 3 types of tooth movements: easy, medium, and hard, okay? This mesial distal crown angulation happens to be in the hard movement category, okay? So we want to make sure we try to avoid that. This is what this looks like. If you're in Invisalign software, fourth thing from the bottom, you want to try to minimize this. We're going to see some videos of this, okay? So right here, we have this as 5.2, but I turn this to 0, and it doesn't look that bad. I would finish this off with a disc. I would kind of recontour it, but you certainly don't want to try to turn this with plastic. You don't want to drive or steering wheel this tooth into position. Also, this tooth is already doing something. It has a rotation attachment. So they're already trying to rotate this tooth 6.6 degrees to the distal. So you really can't rotate and steering wheel this tooth into position at the same time. Those two movements will not happen together. They are two difficult movements. So stick with one movement if you can. I'm gonna play this. So I'll let you guys take a picture. This is a great tool. This is a great reference. I want you guys to take a picture or screenshot or whatever you need to do. I'll go back. These colors do not come on your ClinCheck. This is something that somebody made in the AACA that distributed for free, so you're able to use this. Green, yellow, and red and double red. This is attached to the easiness of movement. So, for example, if you have a ClinCheck and you're looking at each movement, these things are called hinge movements where the teeth open up like a door. It turns out that hinge movements are pretty easy. I know the teeth are swinging and it sounds like it's hard, but the hinge portion, whether it's to the mesial or to the distal, the hinge portion acts like anchorage, and it allows you to swing that too. So that's very desirable. So we see that hinge movements are green. That means good. So that means use it as much as you like. Crown torque. Crown torque is a fancy way of saying tipping. Tipping movements are easy. Tipping happens even when we don't want it to tip, it tips. So therefore, if you can treatment plan tipping into your ClinChecks, that's good. But look at the hard ones. The hard ones, mesial distal translation, root torque movements, and the worst, crown angulation. Hello, steering wheel. That's a steering wheel one. You want to try to remove that whenever you can. So let's take a look here. Why do I default to 0 on crown angulation? Well, if the teeth are already upright, you can kind of disc it at the end. Angulation is not always required for aesthetics. It'd be nice to finish like straight wire. Straight wire doesn't have this requirement, but it's kind of hard with plastic, okay? Tracking is a nightmare for these movements. It's not predictable when you have this movement, scheduled in, and you'll get a lot of refinement. So therefore, for all these reasons, I zeroed out. Only prescribe the movements you actually need, and it takes a lot of practice to learn this. Okay, if you know anyone in AACA, if you ever listen to any speakers in the AACA, they're going to tell you that the refinement rate is about 30%, where the national, at least North American refinement rate is about 150%. What that means is that the people that are getting to 30%, they're not any better than you. The people that are getting to 30% are the people that take out any redundant movements. They take out rotations, they take out root torques. They're left with basically like scooch, like easy stuff, scooch, and proper anchorage. That's how you get your refinement rates down. That's how you get your patients in the chair, out of the chair, and happy. When we take on large, long-term cases, that's not wrong. That's very satisfying. I do a handful a year, but that is not great for GP methodology unless you have a dedicated team. For example, I have a dedicated Invisalign room, and I have two orthodontic assistants. I'm able to manage whatever comes my way. We collectively have enough experience, okay? But if you're just trying to rubber stamp this into your GP practice, you definitely want to minimize any crown angulations. Let's take a look at this video from Dr. Galler.
Good morning to you,
and
and welcome to another edition of ClinCheck Theater Thursday. I am your host, Dr. David Galler, and here is today's ClinCheck tip. All right, this one is a little bit of a nuance, and I'm going to show you how to do it. All right, here we have a lower anterior crowding case. The teeth are a little bit above the occlusal plane. We want to intrude those teeth, and we want to unfold the crowding. So we're going to kind of go like that, and your teeth are nice and straight. Here we are before, and here we are after. Now, if you got the gape, got this, that. All right, now if you just kind of look at these teeth at the end, a lot of people would go, something a little wrong with them. Like they're straight from the mandibular occlusal photo, but straight on, they don't look right. Like there's something wrong with them. And that's because when you have teeth that have worn incisal edges, sometimes the system gets confused about how to line them up. I'm going to show you the problem that happened on these cases, and then I'm going to show you how I easily fix them. Okay, we're going to hit the 3D controls, and this is one of the most important things that I use in 3D controls. I always, when teeth kind of look, I kind of hit on this one. Now, count up 1, 2, 3, 4. The fourth one, oh man, unless there's something major, this should always be 0. This is called crown angulation. That movement, trying to angulate a crown mesial distal, is darn near impossible. The crazier part is that in this case, the teeth look better without picking up all this weird angulation. Like they actually look straighter if they didn't have any of this angulation. Like now, okay, one's a little bit higher than the other, but they kind of just look better. It just looks, the whole thing just looks a little bit more natural. All right, this one maybe has a little bit of extrusion. I don't think we need that. Let's get rid of that extrusion. And this one, we pull down just a drop, maybe right about there. This one, we maybe intrude a little bit right about there. But the overall scheme, these guys just look much better. The difference was getting rid of that angulation. Having that angulation there made all those teeth look a little bit weird. Always look for root angulation. And if you see any of it, just kind of make it 0. The better it is, the more 0 it is, the more those teeth are just straight going down into the socket and look better. This has been a ClinCheck Theater Thursday, and I am your host, Dr. David Galler.
That comes straight from AACA. And how do I manage this problem when you're left with these little nuances at the end of treatment? Shofu single-sided black disc, the best, the best, the best, has made me look like a superstar for all my contouring needs, whether it's Invisalign or bonding or anything. This is my go-to disc. It's thin enough that it's thick enough that it does a good job with one shot. It's thin enough that it gets inside the embrasure. If I have to hug and curve and smooth an incisal edge, it'll do it too. This is my go-to. It's fast, it's quick, and I love it. Okay. Overjet, 1.5 millimeters. So here's the methodology here. Aligner thicknesses are roughly Invisalign thickness is roughly 0.75. Okay. So if we do 0.75 plus 0.7 or 0.7 plus 0.7 roughly gives you 1.5. Okay. Here's the reason. When you remove the trays, you need to have the teeth that don't clang into each other. When you remove the trays, you do not want to have anterior teeth bumping into each other, or else you're going to be prone to a posterior open bite due to anterior interference. It's the number 2 way of getting a posterior open bite. Then you're left with the choice. If you get a posterior open bite via anterior interference, you're left with a couple choices. Do I equilibrate? But you don't know how much you have to equilibrate to get rid of that. Or do you have to do a refinement? And the refinement is going to need IPR. Okay, so you're into significant treatment. So if you treatment plan 1.5 millimeters overjet and you IPR properly, I can almost assure you that you're going to get rid of the headache of having a posterior open bite due to an anterior interference. Okay, so 1.5 millimeters of overjet is mandatory to keep your sanity. Like this case looks pretty good, but it's tight. Just by eye, it's tight. Here's the overjet table right here. 1.4. 1.4 is close to 1.5, but it's not 1.5. It needs more. Okay. Plus, this is an average. This is an average of 1, 1.1, 1.8, and 0.8. So this is not adequate at all. It needs to be 1.5 on each one. Okay. This is your ideal overjet setup, at least 1.5. Okay. I use bite ramps back here. So when I can visualize my bite ramps, I'm satisfied that I have enough overjet. Okay. But the thing to caution is that how is this measurement taken? It's taken from mid-incisal edge to mid-incisal edge of the adjacent tooth. So you know what that means? That means that if you have a deep overbite, if you have a deep overbite and you're measuring incisal edge to incisal edge, now you're measuring on the hypotenuse and you're measuring longer more than actually is. See, this digital software is not like when we went to dental school. When we went to dental school, we had that plastic flexible ruler. We put it up against the lower anterior teeth and we just read off the number when we can, when it cleared the facial, the incisal edge. That doesn't happen in digital world. Digital world, they have to take data points, and the data point happens to be mid-incisal edge to mid-incisal edge, and it measures from there. So if you're on a hypotenuse, you're going to have a skewed number that's more than it actually is. So use your ruler function or Um, use your ruler function, or there's a grid function, okay? But beware, do not get caught with a false measurement, okay? Tools to gain overjet, obviously IPR. If your lower anterior teeth are in the way, you got scooch, scooch. You got to scooch them back, scooch them back. So IPR, infinitely important to gain overjet. And intrusion. We have a deep bite protocol that I can send to Dr. Binu if you guys ask for it. I can send you the deep bite protocol. It's beyond the scope of this talk, but deep bite protocol is uh, very predictable and will help your overjet because intrusion happens on an arc as well. That's why that works. Okay. Munchies helps tray seating and helps tray activation. Okay. This is the concept right here. The trays are made to where the teeth are going to be in the future. The trays, when you insert a new set of trays, the tray is not made to where your teeth are now. The trays are made to where your teeth are going to be in the future. Some force has to bring the plastic to the tooth, grab the attachment, and drag that tooth into position where it's got to be. Everybody follow that concept? You got to go, you got to grab, you got to pull. Those of you that do straight wire, 012 spaghetti wire, you loop it up around the bracket, you grab it, and then it does the job of pulling that tooth where it needs to be. Same type of thing, okay? The force that's needed to stretch the plastic, I assure you, is not the force that it takes to look down at your phone and watch YouTube videos. There needs to be an active force, okay? An activation of the aligners, really, okay? This is what a munchie looks like, okay? It has a slot where the incisal edge fits right in, okay? This is what a bulk pack of munchies looks like, okay? This is called the red munchie protocol. 4 times a day, 7 to 9 minutes each time. Now, what's really important here is that you instruct your patients that when you bite on a munchie, it's silicone. When you bite on a munchie, bite with the force that you would bite your finger. Does that make sense? Because I have an office full of people that chews through their munchies. I'm not sure why. So now I had to start saying, you just need to like little bit, like pretend it's your finger. You're never going to go through your finger. So just bite the munchie like you would your finger. And that's made all the difference. Okay. But 7 to 9 minutes each time while you're watching TV, this you can do when you're watching YouTube videos. And this will activate the trays, stretch the plastic, grab the attachment, drag it where it needs to be. Okay. This is a game changer among all aligner brands. There is another protocol called pink and blue. Okay. I always remember ladies first. So pink goes first. Okay. Pink for the first half, and the density changes a little bit for the blue one. So the second half of the case is blue. And you use them every time the aligners are reinserted for a few minutes and 5 to 10 minutes every night. Okay. You may be familiar with the Chewy. That was before the Munchie. Chewy was like a waxy cotton roll. I've never really felt one, so it's kind of weird to hear that waxy cotton roll. It seats the tray incisally, but it might deflect buccal and lingual. So that was pointed out by the inventor of the Munchie, who says, no, Chewies are not good. Chewies, they deflect the tray. So Munchies has this seating element here where the incisal edges go in. And then these more expensive Munchies have a premolar seating, this like rib thing here. This goes against your premolars and helps seat the tray and the premolars. I use the red ones. These are the red ones. I use them and I like them. Okay. This is what the package looks like. Okay. They also have a vibrating munchie for hard cases. I bought like a 12 pack of them and I just gave them out. As long as your patients are doing something as an adjunct, the case is going to work. Okay. What to buy case by case or standard. Doesn't matter, what you buy. You can go on the Munchies website and they have a whole list of questions that they'll ask you, like how much rotation are you doing? And they'll spell out what the proper one is. But I like the red protocol only because red is easy to order. I don't have to worry about different colors, who's running out of blue, who's running out of pink. Red, one color, one order, one bag, one and done. That speaks to me, okay? Why this matters on Monday is because Munchies means compliance. In clear aligner world, there's 3 things that matter. They're called compliance, compliance, and compliance. If you have a case that's not tracking, well, for those of you who are not using Munchies, when I have a case that's not tracking, I'll sit down with the patient. I'll say, tell me about your Munchie use. Well, doc, I could use more. I could do more. Good. Can you give me more? Can you give me more minutes of the day using the munchie? I think I can do that. Why aren't you using your munchie? Well, I keep it in my car and I forget about it. Have another munchie. Give them out like candy because this will save you a refinement before you have to go to refinement. That's money in the bank, that's goodwill, it's all those good things we talked about. You want to have an adjunct to therapy because you want to have that help. The plastic needs to stretch, it needs to grab the attachment. Your cases will go to completion better. Your tray will have more close to 100% expression when they are activated compared to when they are not activated. Okay, that's why munchies matter. So when I'm stuck, I don't know what to do. I don't know how to get back on track. I'm like, tell me about the munchies. Well, I can use them more. Good. Use them more. This is a game changer. Monday morning. Okay. Figure out the best way for your office. Figure out the best way to order. Okay. If we put all this together, look at some cases. If we put all this together, okay, here is a case. Here is the pre-treatment occlusion. Okay. We see she's heavy on her anterior teeth. Okay. And she's got some open spaces and some crowding. Okay. Here's her overjet. It's non-existent here. Okay. So what are the considerations for this case? We have to solve the crowding. We have to solve her end-to-end bite. And we have to solve her open bite. Okay. Well, to solve the crowding, we got a couple options here. We got expansion. We can procline. We've got IPR, obviously. Which one do we use? Okay. To solve the end-to-end bite, I guess we can procline the upper. We got to IPR the lower. Okay. And to solve the open bite, we have to procline the upper, IPR the lower. We got to make room. Then we got to drop the top. We got to use extrusion attachments. Okay. Here's what my case setup looks like. Please notice the anchorage. We got proper anchorage. Got nice distal wrap. We got good anchorage. All we need is a compliant patient and some munchies, and we know this is going to work. I've got minimal IPR across the front. Okay. Here's my plan. This is how it's supposed to work. Rotate the canines. Scooch the back a little bit. Scooch the interiors back. Drop the top. Okay. Here's before. Here's after. It's about as close to a straight wire finish as I can get with aligners. Here's before. Here's after. Before. After. This is as textbook as clear aligners get. I had a very compliant patient. Okay. Before, after. Improper pictures, I apologize. It was early on. This is what I say. Happy, happier. Okay. This is what I go for. This is what means the most to me. I would never have known about the pre-op and post-op pictures unless I lecture and I compile these pictures. It tells the story of what a game changer, what a change you can make in people's lives. Okay. We have the power to change lives. Okay. We can improve health and function, but we can make a more significant difference in how the patients see themselves. Okay. This is nice. From here to here is nice. Here to here is nice. Okay. This is deep bite protocol that I can send you guys. If Dr. Binu asks me, if you ask him, he'll ask me. 4 millimeters as a matter of routine. Okay. But going from here to here is the best. That's the best for me. That's the best advertisement my patient can give me. Okay. It's the best feeling that I can get for doing this for my patient. This is what gets me motivated to do this every day. This is nice. This is great. But look how nice this is. Happy, happier. Okay. Things your patients can find in themselves. A new job, a new wardrobe. Ever have a patient that just got into a new relationship? This happens all the time. You see the change in people. New outlook on life. Okay. Happy, happier. Okay. Here's a lady here that I always tell the story that she comes in and she comes in on a day that she knows that we're going to take orthodontic records. And I ask her to smile, and she smiles like this. Now, she's a wonderful lady, and I'm not judging, but here's my theory. When people have some crooked teeth, or people have something that happened to their teeth, when they're sitting in your hygiene chair, they're able to tell you, I didn't wear my retainer, or I got hit when I was a kid, or my parents never brought me to the dentist. Well, when someone has to take a picture, they don't have words, they have a picture. What does this picture say about this patient? I'm going to tell you what it says to me, and I know her. This picture says, my teeth are a little crazy because I might be a little crazy. Look at the way she's looking. She's not looking at the camera. She has this clenched bite. That's not natural. But that's not the truth about her. This is the truth. This warm, kind, caring, friendly, inviting person, that is the truth behind her. This will set people free and show you exactly who they are. And I will maintain that for as long as I practice dentistry. As much as you change your patient's life, I implore you to change your life by doing this methodology. Okay. Christina Blocker, Queen of Invisalign, a personal friend of mine. I showed her some pictures. Hey, Christina, check this out. Done in one round. Now let's look at this case. Reverse overjet. I decided to tackle it. I have the methodology for this. Okay. He was done in one round. Do you see this bite? Reestablish proper overjet and overbite in one round. Christina, one round. Look at him. She says, oh my God, seriously? That's incredible, Ron. Is that even the same person? I said, high praise from the Queen of Invisalign. Okay. When was the last time someone high-fived you on a crown? When was the last time you showed a bite wing to someone and they said, oh my God, that is incredible. I love this for you. I love this for you. I love this for the patient. That doesn't happen in dentistry. This is dentistry, but not really dentistry. Okay. It's not easy, but it's fun. And you have to know what you're doing. But it pays dividends and dividends and dividends above and beyond what we already realize with crowns and fillings and doing good for our patients. Okay. This is a noble job. This is a noble profession, but this part allows us to change lives. Align does demographic studies. This goes back to the roadblocks that we give ourselves, and I'm going to be done in 2 minutes. Align does studies about who is the best practitioner, who is the most successful practitioner. Is it a male or a female? Is it someone that practices in the city or out in the country? Is it someone who works in a medical facility or in a strip mall? Is it an old doctor? Is it a young doctor? Who does the best Invisalign? Who does the most? Who has the least refinements? There's a graph. Who has the advantage? As it turns out, nobody has the advantage. There's no male that's better than a female. There's no female that's better than male. The only thing that limits you, between the ears. What is between your ears limits you. If you want to start on Monday and go on a path to being a diamond provider, you can do that. There's no one saying that you can't do that. It doesn't matter about your staff, doesn't matter about your demographic, doesn't matter about nothing. You can do what you want to do, and I maintain that, okay? Once you realize it's changing people, you will be addicted to doing this for people. You'll be fired up like I am about teaching this methodology, okay? Here's a young lady here that I jumped in early on interceptive treatment, like this, boom. Okay, my favorite. Another colleague, Queen of Miami, Gina Marcus. I go, think about how she looks. Look at how she looks and how she feels. This is gold. This is amazing. I love this for her, and I love this for you. Nobody applauds your efforts on a crown. Nobody applauds your efforts on a crown. My favorite one of all time, this gentleman here, he comes in for orthodontic records, and he bites down like we say, like a frat boy, someone who belongs to a fraternity, someone who opens beer bottles with teeth, someone who is just a crazy person because he doesn't have the words to express why his teeth are like that. But that's not truthfully him. This is him. This warm, wonderful, inviting person. This is the truth behind that person. This unlocks people, okay? The change in the teeth is dramatic and the change in the person is more dramatic. Pre-treatment, we saw this case before, okay? But this is how he looks after treatment. This is my friend Jim, okay? He chose this to be part of his success journey. And I told him I was teaching about his success journey. He says, Ron, he goes, it wasn't about the Invisalign. It's because I quit drinking and I started working out. I said, you did all those things to better your life, but you also chose Invisalign to be a part of your success journey. He says, yeah, I guess so, if that's the way you see it. That is the way I see it. This is part of his success journey. It's part of my success journey, okay? Energize your office because these are also all your patients. They don't just live in Shelby Township, Michigan, okay? A clear aligner culture, a patient's clear aligner journey should be part of your success story too, okay? The only thing standing between you and your goal is the story you keep telling yourself why you can't do this, okay? My last question is, are you ready for Monday? Thank you.
Wow. Thank you so much, sir. Thank you so much. We had a full capacity. We actually run out of seat in Zoom. Our Zoom capacity was 100. So there were people waiting, and we had to immediately start a YouTube live. So
Okay.
you are there in YouTube also. So
Thank you.
we had to do that because we never thought we will go above 100. That was excellent.
I
Quickly,
hope you
can
enjoyed
we
it.
have some questions?
Yes.
Any questions? One question I already got through personal chat as well as through Zoom is number one, where to get that quick strip. So
Quickstrip.com.
yeah, I went through the website and I found that it is available online in one site in India. This is new to me also. Okay, so sir, if you want to get out of those people, just get a contact of those people.
I
I
will.
will I will somehow get some kind of a dealer dealing that in India, so that it's easy
I will
for
put you in
my.
touch with the right people.
Yeah, let's work on. I mean, I am not a business person, but I can help somebody to do that in India. Okay. But how many times can you reuse it, sir?
2 to 3 times.
2 to 3 times. Yeah,
Yeah.
I thought so. Like any other strips
Yes.
available in India, this is also 2 to 3 times. But the one available in India, Quick Strip from one company is dealing that in India. That was what I was searching all this time. It's showing around 16,000 Indian rupee, which is very, very costly for 2 times use.
How much is that?
Well, that's like almost $200.
What for what size kit? For the clinic pack?
Uh, Not very clear from the
Okay.
website. I will send you the link. It's
Please.
finishing IPR strip, 0.04 mm quick strip. I'll send you all the detail. Rather, you send me the detail of the
I will.
dealer, and let's see what we can do about it.
Okay.
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 Then can I quickly take some questions? Please share deep byte protocol. Yeah. So you mentioned that you're going to send me some
I will.
article or some data.
Send you
Yeah.
the
Please
protocol.
please
Yep.
do that through WhatsApp
Yes.
in our personal IAO group. Yeah.
Okay.
And I will share it with my people. Okay. Though
Okay.
many are asking for the deep byte protocol. Okay.
4 millimeters.
Okay. So send me the relevant data. I will definitely
Okay.
make sure they get it. Okay.
Okay.
And then your email address is, I'm sure they've noted it down.
I wonder if I got any
Or
emails yet.
all of you can contact me. I will connect
Sure.
you to Sir also. Yeah.
Sure.
So you are there for the annual convention in Orlando?
No.
No. Okay. Yeah, same here. I am having issues with my ticketing with the war and
Okay.
all that. Yeah. So even I may
Oh,
not be able to. All right. So any more questions? Please feel free to ask here or in the groups we are in. Let's
yeah.
not waste their time. It's like Friday morning, peak
Yeah.
practice time for both of them. And thanks a lot from the bottom of my heart for
Thank
spending
you.
your time, your
I
valuable
love it.
time.
I
Okay.
love it.
This is
Thank you.
your
Dr.
major Monday morning practice. Sorry, Friday
Yeah.
morning practice time
Yeah.
here. For us, it's like even delayed is okay. It's like
Yeah.
10:30 p.m. here. That's all.
Yeah.
Yeah.
Good.
Dr. Abraham, do you mind if I share a very quick story that I think will be poignant to this group?
Sure.
I'll make this very quick. So one of the things that Dr. Abraham, as you guys all know, and we should be celebrating, is the new section president here, is that within, well, I think he was elected about 5 months ago, right at the end of 2025. He was getting these types of webinars set up. So we had one in the end of February, I believe, and then one this month, and we'll be looking to do more. And we've been able to bring in people that I absolutely love working with. Dr. Terezi here today has been absolutely amazing. So
Thank
that's
you.
one of the advantages of the IEO growing our membership within India. So please join this group so we can continue to provide these types of opportunities. The other thing I quickly wanted to share and want to make sure that you all understand one of the purposes that the IO is here for, and make sure that you understand that you can take advantage of this, is that the IO is truly set up as an international organization. We are here to support people from around the world, including in India. Right now, we are going through a situation where one of our members is being brought to task, and it's really being driven by an orthodontist who is trying to say that this general practitioner is misrepresenting himself as a specialist. We have gone through every piece of evidence in that complaint and find nowhere where this person has identified himself as an orthodontist. Yes, obviously he uses the word orthodontics on his website and talks about his treatments. However, he also signs everything as DDS. So everywhere and everything that he has shown is properly providing notification as a dentist practicing orthodontics. So the IAO will be jumping in and supporting that doctor. We are going to be working with our legal staff to ensure that there's support that will go to him if the board does try to set any sanctions or anything like that. So one of the things I want people to understand is having a leader like Dr. Abraham makes it very easy. If you do have an issue and you need the IAO's help, you can go directly through Dr. Abraham. He will connect you with myself, and then I will work through the proper channels of the peer review committee who is here to support your orthodontic treatment. So that's one of the reasons why the IAO believes that we can regrow in India, which used to be one of our strongest sections, is having Dr. Abraham right there at the helm to help you get a hold of the IAO when you need that support. So again, if please join the IAO, you can go to www.iaortho.org. You can join right there. I'll make sure to send out links as well. Otherwise, if you feel more comfortable going through Dr. Abraham, please do so. Contact him. He will let me know, and I will get directly a hold of you as well. Whatever works for you. We really need this group to grow so that we can continue this type of educational opportunities and make sure that you have a strong support system when you're practicing orthodontics in India. Thank you so much, Dr. Abraham.
Thank you very much. Thank you very much, Chris, Dr. Ron. Really appreciate your effort and that simplicity in your talk. It was excellent. That IPR part, the Munchie part, I learned a lot from you. I'm really, really happy. So I'm going to maybe have one class for my students with the points which you have told, maybe one class exclusively on IPR.
Yes,
so once again, thank you very much from the bottom of my heart, all of you, all those listeners, for coming in such big numbers. And I promise we'll have more and more sessions. Chris, make sure there are more speakers coming soon. Thank you very much. Good night all, and good day to both of you.
Thank you.
Take care. Bye.
Night, everybody.